Hi guys, welcome back to Codemaster Coach, your medical coding tutor. Today we're on part 4 of our coding guidelines. So if you haven't yet viewed parts 1, 2, or 3, go back and view those videos first, because what you'll learn with medical coding is as you're learning the guidelines, they build. You have to understand part 1 to move to part 2. In order to understand part 3, you have to understand parts 1 and 2. So today we're at part 4. So go back and view those videos if you haven't yet viewed them. All right, so part 4. First of all, let me answer one big question. A lot of coders ask me, Codemaster Coach, what do we code? And my response is we code physician documentation when it comes to ICD-10-CM, PCS, or CPT coding. We code just what the physician says. Now, there are other endorsers in the medical record, such as the nurse, lab, radiology, etc. And those assist us with maybe giving us a little more specification for our coding, like exactly which bone was fractured or, the condition of the patient. But we code based primarily on the physician documentation. So, rule of thumb, always code just what your physician says. Okay? So, how do we pull, based on what our physician's saying, what to code? And I've always been asked, why is it so important for coders to understand the disease process? And I'll admit it, when I first started coding, if I saw broken arm, UTI, or whatever, that's all I coded. I didn't really understand the disease process. But as I'm getting more and more experience with coding, I'm learning the process to a point where I now know when I'm coding what to look for. If I see an abscess, I look to see if they did any type of incision and drainage. Or if I see that the Foley catheter was clogged, I'll look to see if it was flushed, because there's a CPT code for flushing. There's a procedure code or a CPT code for the incision and drainage. So I'm looking for ways or avenues that I can bring in the reimbursement and not lose that additional funding by not knowing to look for it. So as you're coding your patient's charts and you're finding their diagnoses and what's wrong with them, if you have to Google or pull out your medical dictionaries to understand the disease process so that you too can better code it, then do that so you'll know what to look for. And a lot of times that will help you when it comes to querying your physician. You don't want to query a physician and say, you said this, but what about, unless you're knowledgeable. So you too need to understand the disease process, and that will help you to become a stronger coder. All right, so we were at number 4. We're still in section 1. We're down to number 4 is where we finished off talking about the difference between a sign and a symptom. So make sure you view that to know the difference, because now we're going to move on into a little more meat with our coding. Let me show you where we are with our coding guidelines. Okay, remember we finished up with signs and symptoms, and now we're down to number 5. And number 5 says, make sure I get it so you can see it, conditions that are an integral part of a disease process. Conditions that are part of. And it says here, signs and symptoms that are associated routinely with the disease process should not be assigned as additional codes unless otherwise instructed by the classification system. So don't assign those additional or those integral conditions that are a part, those signs and symptoms that are a part of a disease process. We don't use those as additional once we come up with a definitive diagnosis. So remember when I mentioned in a previous video that you have signs and symptoms, and based on the patient telling the physician his symptoms and those being signs to the physician, he comes up with what's wrong with the patient. Well, do we code those additional signs or symptoms? Let me ask you a couple of questions. It says in that guideline we just talked about, it says conditions that are integral part. So if I gave you an example of a patient that was admitted with nausea and vomiting that is due to infectious gastroenteritis. Now listen to that sentence I just said. Patient is admitted with nausea and vomiting due to infectious gastroenteritis. Nausea and vomiting is a common symptom of the infectious gastroenteritis. And so therefore, we don't code nausea and vomiting. We just code the infectious gastroenteritis because it's understood that with infectious gastroenteritis, you're going to have nausea and vomiting. Okay? That rule of thumb says conditions that are an integral part of the disease process are not coded. So that nausea and vomiting is not coded because it's understood that with infectious gastroenteritis, you're going to have nausea and vomiting. Okay? Let me give you another example. Is a patient is admitted with severe joint pain and rheumatoid arthritis. Again, that severe joint pain is describing the rheumatoid arthritis. So once you code the rheumatoid arthritis, it's understood that your patient has severe joint pain. So that joint pain is an integral part of the disease process. So you understanding what's going on here? If it's a condition, a sign, or a symptom that is then defined in a definitive diagnosis, then don't code the signs or symptoms because you've captured it in your definitive diagnoses. However, I knew there was a catch-all, right? You knew there's something that's going to go wrong here. However, give you another example. Patient is seen in his physician's office complaining of urinary frequency, and they have a diagnosis of benign prostatic hypertrophy. Although urinary frequency is a common symptom of benign prostatic hypertrophy, both conditions are coded, reported, because the instructional note in your tabular list under that code for benign prostatic hypertrophy instructs us to use the additional codes or the additional conditions. It tells us to identify those associated symptoms with the BPH, the benign prostatic hypertrophy. What are you saying, Code Master Coach? I'm saying if I looked up the code for benign prostatic hypertrophy, it's N40.1. So pull out your code books and look at code N40.1. And I want to show it to you, those of you that don't have your code books. I'm going to code N40.1. Okay, and let me show you. At code N40.1, notice it's telling you N40.1, benign prostatic hyperplasia with lower urinary symptoms, and it's saying use additional codes for associated symptoms when specified. And we said urinary frequency right there. So it's telling me if any of these conditions under N40.1, if your patient has any of these, use additional codes for the associated symptoms when specified. So in this case, my tabular, my instructional note, remember my instructions video at the beginning said you have to follow the instructions in your book. It told me to use additional codes when any of these symptoms are associated with the condition that's the definitive condition. So unless your code book tells you differently, remember your rule of thumb. If it's an integral part of the disease process, we normally do not code it with the condition. And that's a rule of thumb. Nausea and vomiting is a part of infectious gastroenteritis. Severe joint pain is a part of rheumatoid arthritis. Benign prostatic hyperplasia, because urinary frequency is a part of, normally we wouldn't, but the rule, the instructional note in your code book tells you to use the additional symptom codes along with that. So make sure, remember in my early videos I said you have to abide by your rules in your code book. Okay? All right, now let's move on. That was number 5 on the coding guidelines. Let's read guideline number 6. 6 says, conditions that are not an integral part of the disease process, and it says additional signs and symptoms that may not be associated routinely with the disease process should be coded when present. Okay? If it's normally not associated with the condition, capture those codes. Those are additional problems that your patient is experiencing. So these are additional. Let me give you some examples. And I tried to find some examples that would really stand out for you guys. A patient is admitted by ambulance following a cerebral vascular accident suffered at work. The patient was in a coma, but gradually recovers consciousness. Diagnosis at discharge is reported as cerebral vascular thrombosis with coma. In this case, coma is coded as an additional diagnosis because it's not implicit in a cerebral vascular accident. So patients that suffer a cerebral vascular accident or a stroke, not everybody goes into a coma. This particular patient did. So because it's not usually an integral part of the disease process, then we code it. So you'd code the cerebral vascular accident, but then you'd also code coma associated with coma. And there's a code that captures the coma as well. All right, another example. A 5-year-old boy is admitted with 104-degree fever associated with acute pneumonia. During the first 24 hours, the patient also experiences convulsions due to the high fever. Both the pneumonia and the convulsions are reported because convulsions are not routinely associated with pneumonia. Fever is commonly associated with pneumonia and is not an additional code. So again, you got to have a basic understanding of the disease process. What exactly is going on with your patient? And then based on your knowledge, in this case, this 5-year-old's fever got so high that the patient started going into convulsions, started having seizures. That normally does not happen with pneumonia patients. So because the seizure, the convulsions don't normally happen, we code that. However, fever is an integral part of the disease process. Therefore, we don't capture the fever, but we do capture the convulsions because this particular patient did go into convulsions in addition to the pneumonia. All right, guys, so hopefully in this video I've expressed to you the importance of understanding exactly what's going on with your patient so that you'll know what conditions to capture, what conditions to code. All right, so that's 5 and 6 under 1B, number 5 and 6 on the coding guidelines. Again, if you haven't found them, go to the website, cms.gov. In the search box, put 2018 ICD-10-CM guidelines, and it'll give you a draft of the 117-page coding guidelines, which are our rules. And these are what we're learning right now, what we're following. And I'm trying to break this stuff down to you. So if you don't get anything else out of today's video, understand what's going on with the disease process so that then you'll know what to look for and what to code. Okay, guys? I'll see you in the next one. Keep studying. Thanks.